I am actually going to introduce myself. I am the first speaker of this session, actually chairing it, and then I'll be followed by Dr. Merlini and the other speakers. I'm hoping everyone can see my screen and can hear me. So I'll begin. These are my disclosures. And so the objectives of my presentation today are to discuss the tests we use in patients with monoclonal gammopathies and those with suspected AL amyloidosis, and also how we use these different tests to monitor for response to therapy, as well as to monitor for progressive disease. And this is a drawing of bone and bone marrow, not the kind of pictures you're going to get to see from Dr. Ritter a little later. This is just demonstrating that in the normal bone marrow, we should see up to 5% of plasma cells. These should be polyclonal, and they're there to make antibodies to fight infection or response to vaccination. But in the lower part, we have the situation where we're dealing with a clone of plasma cells, as we can see in patients with multiple myeloma or amyloidosis. And in this case, those clones of cells also produce antibodies or parts of antibodies, and we can detect those clonal paraproteins with some of the tests I'm going to discuss. So going back to some basic immunology that you probably remember from years ago, when we look at an antibody, it's composed of both 2 heavy chains and 2 light chains. The 2 light chains are kappa or lambda, and the heavy chain can be IgG most commonly, but also could be IgA, IgM, IgD, and IgE. And in most of the diseases we're dealing with, such as multiple myeloma, typically there's an entire intact antibody, so we can see a heavy chain and light chain. In our patients with light chain amyloid, the majority are secreting just a light chain. And so the test that we start out with is serum protein electrophoresis. You've heard this mentioned other times throughout the day so far. And this is a technique in which serum, or we can also do this with urine, but a sample of serum is placed on an agarose gel exposed to an electric current, and the different proteins are separated into 5 major fractions based on their size and electrical charge. And one note in terms of urine, in our patients, especially with amyloid, there's very little of the clonal protein present. So urine samples really should be 24-hour urine samples that are concentrated to do this. But this is a sample of a serum protein electrophoresis. You can see it separates into 5 bands. The largest band should be albumin, which is the first band. And then the other bands are given names based on their placement with alphabetic letters. So alpha 1, alpha 2, beta 1, beta 2, and gamma. And the gamma contains most of the immunoglobulins, as you can see from this picture here. But sometimes the immunoglobulins can also show up in the beta regions and be difficult to identify. It's also very important to know that the protein electrophoresis test can quantify the monoclonal spike, but it can't tell us the subtype. So it may be able to tell us that there is a spike present. It can give us a value of 2 grams per deciliter, for example, but it can't tell us the subtype. And in less than half of AL patients, we find an intact immunoglobulin paraprotein. And in many others, the concentration is so low that we really can't detect it with this test. And this is a sample of what this actually looks like. As you can see, the blue lines represent agarose gel, and it's now been stained for proteins. And what you see above is the densitometric scan of that, and you can see the different bands that we've talked about. And this is a slide that shows a variety of patterns over on the right. The one we're most interested in many of our patients is those that have a monoclonal spike or a paraprotein. And you can see in the gamma region, there's this very large spike. It's actually even larger than albumin. And this is pretty typical for our patients who have multiple myeloma and MGUS. The majority of patients with light chain amyloid, if they have a detectable spike seen on an SPEP, it's usually not this large. And you can see in the middle of the slide here, this shows a normal gel as well as that from a myeloma patient. And you can see right here in the middle, this very densely staining abnormal band that's the monoclonal gammopathy. And this is a sample of what some of these tests look like. Reading these, I think for many in the audience that are not oncologists and hematologists, it's kind of like me trying to understand an echocardiogram report and all the things that are there. But the key thing that's noted here is that there is an abnormal restricted peak in the gamma region. Again, that just determines is a representation of where that peak is in those different peaks. So it's in the gamma region. It measures 1.9 grams per deciliter. Again, this doesn't tell us what subtype it is. Just because it is showing up in the gamma region, it doesn't mean that it's IgG. And in order to detect that, we do a test called the immuno-fixation electrophoresis, or often what we call the immuno-fixation. And this is a similar sort of thing. A sample of protein is loaded onto these different columns of the gel, and again, run against an electric current, and then the proteins are stained. But in the columns that are labeled with IgA, IgG, IgM, kappa, and lambda, specific antisera are placed that will light up that protein. And the advantage of this test is, again, not only can it tell us the exact subtype of protein, the monoclonal protein the patient has, but it's much more sensitive. And the sensitivity of this test, we can detect down to about 12 to 15 milligrams per deciliter. The limit of detection of a protein electrophoresis about 100 milligrams per deciliter. And again, for many of our patients who have suspected light chain amyloid, the protein electrophoresis will look normal and we'll only see an abnormal protein by doing this test. And this is an example of a gel on a patient with an IgG kappa. As you can see on the left, this is just the standard SPEP that we talked about. This large band is seen here in the gamma region. And as you can see, when you look at the corresponding bands, you can see a band in IgG and kappa that are at the same position. And that lets us know that this patient has an IgG kappa monoclonal protein. But it's very important to recognize, and I think this has been brought up a bit, that monoclonal gammopathies, finding this monoclonal protein in a patient, is not always myeloma or AL. And in fact, the most common thing we see in terms of why someone would have a positive monoclonal protein is monoclonal gammopathy of undetermined significance, which is present in more than 5% of our patients over the age of 70, over 3% of patients over the age of 50. And this is the prime ages that patients who have other forms of amyloidosis present. Other diseases that can be associated with MGUS, excuse me, I'm going to take a drink here. Other plasma cell dyscrasias, monoclonal gammopathy of renal significance, POEMS syndrome. There are also B-cell lymphoproliferative disorders, such as chronic lymphocytic leukemia, Waldenstrom's macroglobulinemia, non-Hodgkin's lymphoma, that can present with monoclonal gammopathy, as well as a number of non-hematologic disorders, including things like monoclonal gammopathy-related neuropathy and a variety of renal disorders. The other test that became very important and really made a big impact on our ability to diagnose and follow patients with amyloidosis is a serum-free light chain test. Excuse me. Ever since I moved back to St. Louis from California, my allergies have been a problem. The serum-free light chain test is a method to identify the free light chains that are circulating in the serum. And so this test looks for an epitope that's hidden when the light chains are attached to a heavy chain and an attacked immune globulin. And so you can see in these kappa and lambda free light chains, this yellow exposed surface is identified in the free light chain test. It's also important to know that this test is not specific for monoclonal light chains, so it detects all light chains. All of us have a small amount of free light chains circulating, and these can be detected at a very low level, typically in the 2 to 3 milligram per deciliter range. The advantage of this test is that when we look at using a test such as a serum protein electrophoresis and immuno-fixation, we can identify up to 95% of patients will have an abnormality in patients who have light chain amyloid. But if you add the free light chain test, you can identify almost 100% of patients who will have at least one abnormality in one of these tests. This is a sample of what the test looks like, and this you can see they report both the free lambda light chain and the kappa light chain. In this patient who has lambda light chain amyloid, you can see that their lambda is elevated at 13.2 milligrams per deciliter, or 132 milligrams per liter, and they have an abnormal light kappa to lambda ratio. One of the things that I would point out is there are two methods of reporting this. It can either be reported in milligrams per deciliter or milligrams per liter. And very important as you're looking at different tests to make sure you know what units you're using. The other important thing that's not reported is the measurement we call the free light chain difference, or DFLC. And this is calculated by subtracting the unaffected free light chain from the affected free light chain. So in a patient with lambda light chain amyloid such as this, we subtract 1.55 kappa from the 13.2 lambda, and we get a free light chain difference of 11.5 milligrams per deciliter. And again, that's important because this is a number that we're going to follow in order to determine if the patient is responding to therapy. And in one of the staging systems from Mayo Clinic, this is a number that's used to calculate a patient's stage. There is an impact of renal function on free light chains. The free light chains are excreted by the urine, and as we see worsening renal function, we see an increase in the kappa and light chain values in patients. And as you can see in this left panel, as patients have worsening CKD, we see an elevation of both the kappa and lambda, and the kappa rises a little faster. And that's represented in the right drawing. As you can see, the free light chain ratio rises over to worsening renal function. And this has importance because you can have a patient who does not have AL amyloid, who does not have a monoclonal gammopathy, but will present when you're doing testing with an abnormal ratio. And sometimes these patients are sent for referral, even though it has nothing to do with amyloidosis. And there are a lot of other things that can impact the free light chain test. So in addition to renal dysfunction, really anything that's related to infection or inflammation can cause elevations of the free light chains. Typically in these situations, aside from renal function, we see, normal ratios, but elevated values. These are the hematologic response criteria for AL. These are in your syllabus. I won't go over them in detail. But the key thing is our goal is to get patients into a VGPR or better, and that's represented by a free light chain difference of less than 40 milligrams per liter or 4 milligrams per deciliter. As has been mentioned before, and I'll just go through this briefly, just finding a paraprotein on one of these tests, an amyloid deposition, does not automatically mean a patient has AL amyloidosis. And in a couple of studies that are here, we could find in some, one of the studies from Dr. Stanchwala's group, looking at 217 patients with TTR amyloid, over a third of those patients had a coexisting MGUS that was not related to their amyloid. I think one of the reasons Dr. Lenihan gave me the title of this talk is to answer a question about how do we make decisions about when to retreat our patients with amyloidosis. Excuse me. And I think it's much easier to treat our patients with myeloma who have relapsed and
I'm very sorry about the problems with the audio, and again, I'm running out of time, so I'm gonna wrap this up. And
no, Keith, it's okay. It was my fault for being late before, so we'll give you a few more minutes.
Again, I'm not sure if
So we hear you now.
Okay, yeah, I'm very sorry. I don't know what happened here. Again, I only have a minute, so let me just wrap things up. I guess what I really want to focus on is in the last minute is when to restart therapy for light chain amyloid. And the answer to that is that there is not a clear consensus for when to do this. We have many different clinical situations. We have patients who present with hematologic progression, but no organ progression, patients who have hematologic progression and organ progression, and then patients who have organ progression, but they remain hematologically in remission, even in complete remission. And the real question is, in these patients, how do we differentiate between organ progression and deterioration due to worsening amyloid deposition or just deterioration of the organ after the initial injury?
Hey, Keith, why don't you take a few extra minutes if you need to? We watched you at your slide where you were talking about CRAB and treatment of myeloma, so we'll just have to go over a little bit. That's okay.
Okay, yeah, let me, I won't go back to the myeloma. Certainly we can answer that in questions, and I apologize for the audio issues that we had. So again, in terms of our patients who have hematologic and organ progression, those patients clearly should be treated with plasma cell-directed therapy. These are patients who have an elevated free light chain or an elevated paraprotein, and we see signs of progressive organ dysfunction from their amyloid. But for patients who have hematologic progression on its own without organ progression, it's unclear what the criteria should be. And I think it's clear, and you'll hear from Dr. Merlini, that the current criteria are probably not sufficient. One of the criteria that we use for patients on clinical trials is a free light chain difference of greater than 50 milligrams per liter, but about 20% of our patients won't meet those criteria based on having low light chain amyloid. And we know that once patients have organ progression, their survival is much worse. And this is a study from Dr. Merlini's group looking at patients with AL amyloid who received second-line therapy, and those patients who had no pro-BNP progression as a sign of their cardiac disease had a much improved survival than the patients who at the time of retreatment already had organ dysfunction from amyloid. And so determining when we need to reinstitute therapy is really based on not just the absolute light chain number, but things such as what the baseline free light chain was at diagnosis, what the best response was. And again, we have to take into account those patients who have low free light chains. One of the things that Dr. Molini's group has shown, as you can see below, is if you use some stricter criteria to look at patients who relapse, you can often detect patients having progression based on these high-risk disease DFLC progression about 6 months prior to actually having organ dysfunction with cardiac. And so I'm going to stand with one slide here just to show the uncertainty that we have with how to treat patients. And this is a survey that was sent out to 100 amyloid specialists and then asked their opinions on how they would approach patients with different clinical scenarios. It was a very lengthy survey asking all sorts of things. But this is one I think that's representative of the problem we have in the field, and that is you have a patient who's achieved a hematologic complete remission, now presents with cardiac progression, and they ask these amyloid specialists, what would you do? And what you'll see is that there's not a single right answer, that about a third of patients said they might treat this patient just with cardiac progression, but most would want to see some changes in their paraproteins, their light chains, and again, what the criteria were to decide someone needs therapy is all over the place. And because of time, I'm going to skip this. It's just a similar question about patients who had a VGPR. So again, I apologize for the problems with audio. I'll answer any questions that I might have missed, but I hope I give you a better understanding of the testing we use in patients with monoclonal gammopathy such as AL amyloid, the need to do this testing, which should be a protein electrophoresis, immuno-fixation, and free light chain in order to help diagnose these patients and use these studies in order to help follow patients on therapy. And most importantly, clinical trials are necessary to help us expand our definitions of progression requiring intervention. So thank you very much for your attention. And
yeah, so Keith, thank you so much. And I'm sorry that I had my own technical issues there. I didn't even get to introduce you. So I'll introduce you now, even though you finished. So Keith is the co-director of our Amyloid Center of Excellence and professor in the BMT section at WashU, and he's the assistant program director for the fellowship. So